The biliary system, or otherwise known as the biliary tree, comprises of the accessory organs of the GI system. And those organs are the gallbladder, the pancreas, and the liver. These organs secrete enzymes that help us digest food, so they're instrumental in ensuring we have adequate nutrition. The gallbladder is a pear-shaped organ that holds 50 mLs of bile for us to use PRN. Bile is used to digest fat. So after we eat a fatty meal, the gallbladder is going to start contracting. And when it starts contracting, the bile flows into the cystic duct. The cystic duct meets the common hepatic duct and it becomes the common bile duct. So the bile flow goes from the cystic duct to the common bile duct, and it's going to enter the duodenum via the ampulla of Varda. Okay? There are 4 terms I need you to know, and they're listed here in order of severity. So the first term is cholelithiasis. And if you recall, lithiasis means stone, chole means gallbladder. So this refers to gallstones. The second term is cholecystitis, which means inflammation of the gallbladder. The third term means choledocholithiasis, which means a stone is in the common bile duct, which can lead to cholangitis, which is a life-threatening disorder if a stone is stuck in the common bile duct. That can happen. Cholecystitis, as I mentioned previously, is inflammation of the gallbladder wall. The most common cause of cholecystitis is cholelithiasis, which is, as I mentioned previously, is gallstones. However, gallstones don't always cause cholecystitis. You could have gallstones and never know about it, just find out about it on a random ultrasound that you have. And then cholecystitis could be with stones or without stones. And this term for stones is calculus. So acalculous means without stones. Okay, and that could occur when patients are in a position where they don't need to use bile. They have biliary stasis, such as people on long-term TPN use, people with high levels of estrogen, because that slows down peristalsis of the cystic duct, and people with sepsis or hypovolemia. Cholecystitis can also be acute or chronic, and we'll talk about both of them. The risk factors for cholecystitis can be easily remembered by the 6 F's. So they stand for fair, fat, 40, female, family, and fertile. And fair means Caucasian. So those are the characteristics of somebody that is going to be prone to cholecystitis. More risk factors for cholecystitis include eating a high-fat diet, having a sedentary lifestyle. Obesity is a risk factor for cholecystitis. Crohn's disease is also a risk factor. Any condition where you're starving your body, you could be at risk for cholecystitis. If you have rapid weight loss, that's another risk factor. People that go on like ketone diets or lose a lot of weight really quickly, like on liquid protein diets, what that does is it stresses your liver to increase cholesterol. It makes more cholesterol. And high cholesterol has been also tied to cholecystitis. Gallstones are made of cholesterol, but scientists aren't sure what the tie is between high cholesterol and gallstones, but there is a correlation between those two. The signs and symptoms of cholecystitis include pain in the right upper quadrant with radiation to the shoulder, especially after eating a fatty meal, which makes sense because the gallbladder will start to contract after you eat a fatty meal, and so they can get biliary colic from that. The patient will have a temperature because it's an itis. There's inflammation of the gallbladder. Nausea and vomiting are common. Dyspepsia is common. Eructication and flatulence. So eructication is belching. Flatulence, I think you know what that is. So air is coming out of both ends. Um, they'll have a positive Murphy sign and rebound tenderness. Murphy sign and rebound tenderness are elicited by providers because it's deeper palpation. And with Murphy sign, it's they have pain with deep inspiration during right subcostal palpation. So like right under the rib cage, and the provider presses while the patient takes deep inspiration. Rebound tenderness occurs when the provider actually they're doing deep palpation, but when they pull the pressure off of the palpation, that's when the patient feels the pain. That's called rebound tenderness. Biliary obstruction occurs in chronic cholecystitis and also choledochal lithiasis. If you recall, I talked about it earlier. It refers to a gallstone being trapped in the common bile duct. When there is biliary obstruction, the flow of bile is obstructed. So the patient is going to become jaundiced. Remember, the liver makes the bile, the gallbladder stores it. In either event, the flow of bile is going to be obstructed. So therefore, the bile salts leak into the skin and cause yellowing of the skin and pruritus, like intense pruritus. Also icterus, which means yellowing of the sclera of the eye. Clay-colored stools, because bile gives our stools the brown color. Steatorrhea means fatty stools. They're foul smelling and they float. They're floaters. And the urine is dark and foamy. It could look like beer, like a brown colored beer. And then pruritus I talked about. That's intense itching of the skin. With acute cholecystitis, you'll see a high white count. If the patient has biliary obstruction, you're going to see the other labs. Otherwise, if it's just acute cholecystitis, it's a high white count. If there is biliary obstruction, there's going to be a high bilirubin because the bile can't flow. There'll be high amylase and lipase only if the pancreas is involved. And biliary obstruction with gallstones is one of the most common reasons for people to develop pancreatitis. So amylase and lipase only when the pancreas is involved. High alkaline phosphate could be increased with biliary obstruction, and then high transaminases, the AST and the ALT, those are like the troponins of the liver. If the liver is stressed, you're going to have high levels of those liver enzymes. And most specifically, the alanine transaminase, I can hardly pronounce that, the ALT, that will be elevated if somebody does have a gallstone and they have pancreatitis. And so that's one of the factors you look at to determine the cause of pancreatitis. Diagnostic testing for cholecystitis involves a right upper quadrant ultrasound. That would be the first test because it's the least invasive. A HIDA scan may be done. This would be done in nuclear medicine. They inject a tracer, a radioactive tracer, into the vein, peripheral vein, and they watch it through the biliary tree. And it's used to evaluate like biliary obstruction or bile leaks. And then the MCRP is like an MRI of the biliary system. It does use a dye. It's not iodine based. It's called gadolinium. Anyways, you do have to watch for renal problems afterwards. So make sure you're checking the BUN and creatinine beforehand, holding metformin beforehand, just like you would for contrast dye with the CT. Treatment for acute cholecystitis can involve doing nothing, sending the patient home if they come to the ED with pain, and explaining they need to go on a low-fat diet, encourage weight loss. Patients can take bile-dissolving medications. Opioids, especially if it's acute and they have severe biliary colic, you would give opioids, and ketorolac is another option. That's an NSAID. ESWL, we talked about that with nephrolithiasis, so same nursing interventions. And of course, surgery, the most common surgery is the lap chole. One treatment for cholecystitis is a laparoscopic cholecystectomy. They're really common. When I lived in Cobb County, Georgia, we did these all the time. I am surprised there's anybody living in Cobb County, Georgia with a gallbladder still. We did so many of these. It's a minimally invasive surgery. And if you look at this picture here, I've got these little laparoscopic dressings, little 2x2s with tegaderm over them. And there's one in the umbilicus. And these are where the surgeon puts the trocars in to do the surgery. You do still need to medicate for turn, cough, and deep breathe, because if you look here, the gallbladder is in an area where when you're breathing, it's going to cause pain. So make sure you medicate them so they will turn, cough, deep breathe, and use the incentive spirometer. After this surgery, it's common to get pain in the shoulder or thorax, and the reason is because they inject the abdominal cavity with gas so that the surgeon can see what they're doing inside the abdomen. So the best thing when they complain about shoulder and thorax pain is for the patient to ambulate. So encourage them to get up and ambulate. They can usually bathe or shower right after surgery. They can usually resume activities within a week. And they should eat a low-fat diet and introduce fatty foods one at a time. I had a surgeon that was really strict, and they couldn't drink carbonated beverages after surgery for like a week until they went and saw him, and they couldn't use straws because, those carbonated beverages and straws can cause gas. And after surgery, the best thing to know that the bowels are working again or that peristalsis has returned is that flatulence is occurring. The open cholecystectomy is not performed that commonly anymore. When I first came into practice, this was the only option if somebody needed gallbladder removal. And now it's reserved for people that have severe biliary obstruction, like due to cancer or chronic disease. Patients are given prophylactic antibiotics. They will have a JP drain after this type of surgery. It's going to drain serosanguinous fluid, which you would expect with JPs after surgery. However, for an open cholecystectomy, it may be bile stained for the first 24 hours, the drainage. The patient may need a T-tube, and I'm going to show you what that looks like. It's common to need a T-tube when they do common bile duct explorations. When the dressing is going to be on the right upper quadrant. And so when you're checking your patient for bleeding, don't just check the dressing. Make sure you're turning patients over to the side because blood can drip down the side of the dressing on the patient's side and you won't even notice it. And they could be laying in a pool of blood. So make sure you always turn patients to assess for bleeding after surgery. And make sure they're medicated because they definitely do not like coughing and deep breathing because the incision is in the right upper quadrant. This is a picture of a T-tube, and it got its name because it looks like a capital T. The capital T part is put into the common bile duct during surgery so that bile will still flow, and it will flow out into a drainage collection bag after surgery. So it's going to remain in place until the edema subsides. I remember some of these staying in for like 9 days after surgery. Patients were in the hospital that long. You need to monitor the drainage closely and make sure that the T-tube is not kinked in any way because it can easily get kinked when the patient is sleeping, etc. Expect about 500 to 1,000 milliliters per day. It drains bile, so that color is golden to dark green. Monitor for the return of brown stools and monitor for peritonitis. Remember peritonitis, I talked about it in the renal lecture when I talked about peritoneal dialysis. So you're looking for a high white count, a board-like abdomen, and guarding because it's very painful.